Thank you for tuning in to the HS Foundation's lecture series. The HS Foundation is a nonprofit organization focused on improving the lives of people affected by HS through advocacy, education, and research. Our vision is to live in a world where no one suffers from HS. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education through the joint providership of the Pennsylvania Medical Society and the Hidradenitis Suppurativa Foundation. The Pennsylvania Medical Society is accredited by the ACCME to provide continuing medical education for physicians. The Pennsylvania Medical Society designates this virtual activity for a maximum of 1.0 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in this activity. To claim CME for this webinar, you will access the completed webinar button you received in your confirmation email. From there, you will indicate which webinar or webinars you viewed. This will then provide you with the link to claim your CME for each course. If you have any questions, simply email info@hs-foundation.org. Thanks again for joining us. The presentation is about to begin.
Hi, everyone. I'm Jocelyn Kirby. Thanks for joining us. I'm joined by Tiffany Mayo.
Hi, everyone. I'm Tiffany Mayo. I'm an associate professor at the University of Alabama at Birmingham.
And I work at Penn State. And both of us are representing the HS Foundation to help bring you this session on first-line management. Some of our other sessions are on diagnosis of HS or for people in the urgent care or emergency room, how to deal with HS management in that setting. Here, we really want to focus on how do we bridge from your office to ours. You might be a family and community medicine provider. You might be in general internal medicine or pediatrics. This is where so many of the patients are first getting their diagnosis. And so we want to help you understand what is HS, and we're learning so much about the pathogenesis. And then how do we take that information about pathogenesis and turn it into, here's a therapy that you can do as the referring person to us to help that person have something in their system that's helping them or on their skin until they can get to our office. So this talk, we did develop it based on the best available evidence, including the current guidelines, and we'll show you those figures multiple times during this talk. This program was developed on behalf of the HS Foundation, and Tiffany and I are both doing this for that purpose. You can see our personal disclosures and conflicts on the HSF website. So goal of this talk is, again, to revisit that HS is a chronic condition. It's chronic episodes of HS kind of stitched together over time. That it is importantly an immune-mediated condition. And so many of our patients come in thinking that they have infection after infection after infection, and then conclude that their immune systems are deficient or defective in some way, and that is not the case. We want to help give you the tools with what you can do for that acute flare-up, but I think almost more importantly, what can you do for the patient chronically over the next month, 2 or 3, that they can use until they get into our office. And I'm going to turn it over to Tiffany.
Thank you, Jocelyn. It can be helpful to first think about the impact of HS on our patients. As you can see here, a quote from one of our patients: "It became a nightmare. I was suffering physically and emotionally." And that's what we hear from our patients over and over again. It can be helpful to think about some of the conditions that you may see more frequently when we think about the impact of HS. So the quality of life of HS has been shown to be worse than that of psoriasis, worse than that of eczema, which we are more familiar with sometimes. And also hospital readmission rates are comparable to that of CHF. So these patients are often in and out of the hospital due to those frequent flares that they're having if they're not adequately managed. So this results in more use of high-cost care, such as ED visits, urgent care, inpatients, compared to those with psoriasis or neither condition. Those frequent flares have patients describing it as basically a roller coaster from hell, and it causes a lot of issues such as missed work, missed school, and missed opportunities for these patients. The impact of HS leads to challenges often related to delays in diagnosis. And as Jocelyn mentioned, we do have other PowerPoints. And so there is a PowerPoint on how to diagnose HS that can really be helpful in declining and decreasing some of these delays. So the average patient sees about 5 providers over a total of 17 visits before they're actually given a diagnosis of hidradenitis. So that's a lot of visits. That's a lot of time to suffer with HS, and that's a lot of time for chronic changes in the skin to occur. The mean delay is about 7 to 10 years, we know from literature, and that results in missed work with an average of 34 missed days per year. 10% patients report being fired, and over 20% patients feel like they've missed promotions due to just challenges related to their HS, delays in diagnosis, and not getting the appropriate management. So let's move on and talk about the clinical manifestations and diagnosis.
Perfect. So I think that Tiffany hit on, some of these statistics that if I had to really empathize with that position, to not know why you keep getting these painful things is pretty annoying. To be told repeatedly that you have infections can really be pretty hurtful, I think, to some of our patients. And I would say that one of the things that I have appreciated more over time in taking care of people with HS is the power of being given a name for what's happening to you. And so to have someone come in and for you to be able to say, I hear that this has been happening multiple times over the last couple of years. I don't think that these are just infections happening over and over under your arms and your groin. I think it's something else, and it has a name called hidradenitis. And just at that small conversation, people, are just so relieved to have that name. And I want you to have that, just like incredible joy of like giving people that kind of experience. So we're going to go over how to do that. And to try and cut down on stories like this that are quoted down below, which is it took 20 years for somebody to eventually get that diagnosis for what was going on. So HS is probably not as uncommon as initially thought. Statistics vary pretty widely from even 1 in 1,000 up to 4%. Probably the true estimate is somewhere around 1%, we think. That might sound pretty uncommon, but it's actually as common as rheumatoid arthritis and maybe half as common as psoriasis. HS does seem to have a prevalence for more women than men, but disease can be mild in both or severe in both. Our people who are Black in our communities have a higher rate of HS compared to people who are white in our communities. We really lack a lot of information on being able to give you information about rates in Hispanic patients in our communities. But I would say, Tiffany, and you can, correct me here, I feel like there is a higher rate. And I think we really do need some information on that group.
I agree. I feel like minorities are, there's a higher prevalence there, even though we don't have the data to necessarily support all ethnic groups, we do tend to see it clinically more common there.
Thank you.
Mm-hmm.
And so right now, we do see in the data sets onset of disease documented in people's 20s and 30s. But going back to what Tiffany said, people probably have this condition anywhere from 3 to 12 years before they get the diagnosis. And so in some of the other data sets, it seems like people develop HS kind of after puberty, as early as maybe 8, 9, or 10. Especially in our patients who also have Down syndrome. Onset seems to be a little bit earlier. In otherwise adolescence, seems like it's in teens and 20s. Mm-hmm. Clinical characteristics. What are people noticing? Well, you can see from the images here that some lesions almost look like acne, though when you palpate these, they're actually broader than what you appreciate with the eye that is pink. Similarly, this is the abdominal fold, varying colors from pink to almost like a purple and violaceous. In our patients with skin of color, again, you appreciate inflammation, not so much as a bright red, but more of a violet color and with overlying pigmentation. All of these lesions cause pain, 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 and more pain are usually the top 4 things that people mention first. Itch, I think, is under-recognized as a symptom of HS, but the drainage and the odor that goes along with the drainage are also really impactful symptoms of the disease that we're trying to manage. And so again, what you're seeing across all of these images are typical manifestations of HS in typical locations for HS. These are inflammatory nodules, they are abscesses, and there's tunneling. And I'll point out that sometimes what looks like on this far right-hand picture, 2 separate lesions, when we palpate these, you feel sort of like a little bit of a curve or an elevation connecting the 2 of them. And that would lead you, again, to conclude that this is tunneling. But again, these are all things that if you see, I would think of HS first. When it comes down to history, because sometimes people come in on a good day, they don't have any of their active lesions. And one thing that we can do is leverage our history. And so we can ask, have you had boils in the last 6 months? And if the answer is yes, asking them how many they've had. And if it's been 2 or more episodes of 2 or more boils, then there's a very high chance that when these are happening in the typical locations, like under the arm or in the groin, like I've showed you some pictures of, that the positive predictive value of this is incredibly high, 96%. And so to move toward the opportunity of saying to a patient with these, there might be a chance that this is a skin condition. And if you want to say the name, that's great. If you don't, you just want to say, I want to refer you to somebody who might be able to tell us if this is, a skin condition, or if there really is maybe something like an infection. I think hedging a little bit with the chance that there might be some other explanation, I think is the opportunity other than infection, which is what the person has probably heard. And I'm going to hand it back over to Tiffany.
All right, thank you, Jocelyn. I'll just add to that, especially for those acneiform appearing nodules on the chest. When we're seeing those, sometimes the patient may not even be coming in for HS, but seeing those and asking those screening questions can really help with the earlier diagnosis for HS in those patients.
Great point.
So let's talk about HS pathogenesis. Of course, as Jocelyn said, a lot of patients come in, they've been told over and over again that this is something else, that this is an infection. And so we can talk a little bit about the pathogenesis so that you can feel empowered when you're making the diagnosis of HS to help patients understand what is this disease that they actually have. So HS is a chronic inflammatory skin condition. Patients may feel like it's an infection. A lot of providers may tell patients initially that it's an infection because it looks like boils. However, we understand that HS is due to 3 main things that happen. Now, it is multifactorial, and we don't completely understand the pathogenesis. We've moved away from this idea of it being solely an apocrine disease, and so we now think of it more as 1, follicular occlusion, then leading to follicular rupture with an intense immune response, and then finally developing into a chronic state with recurrent lesions, scarring, tunneling, and persistent drainage. So when we think about that follicular occlusion, there may be a genetic predisposition, for example, for like keratinization around the follicle, cyst development. So that may be genetic, and then there may be external factors such as smoking, or you can see over here on this slide, obesity, other things that may cause friction that could then increase the likelihood of that follicular occlusion. But once this disease in those patients who are predisposed to it gets started, it usually then leads to this inflammation, and then patients often go on to develop the chronic scarring. HS is inflammatory. It can be worsened by microbes, but it is not an infection. And it's important that we help our patients understand this, especially when we talk about the treatment options that we often use. So it's been found that there's actually fewer bacteria in HS skin compared to controls. There are increased anaerobe bacteria in HS lesion, and this more correlates to HS severity. So we talk about this in terms of Hurley staging. So the more severe Hurley stage 3, there may be increased anaerobes compared to Hurley stage 1. And there's also a lower diversity of bacteria and fewer commensals in our patients with HS. So we don't think of HS as an infection at all. We know that it's an inflammatory condition. That doesn't mean that there may not be some bacteria there and that bacteria may just be there, or it may be kind of inciting or worsening some of the inflammation, but it definitely is not the cause of the inflammation. Now, patients can get infected when they have HS, but there will be other signs that will lead you to a clue of infection, such as fever, chills, other things that we look for in infection, but we don't think of HS as an infection. And so we don't often culture HS lesions. Jocelyn, is that what you typically do in practice?
Yeah, I don't tend to do a lot of cultures. And I think the way you explained it is really perfect. So I really want to emphasize that HS is first and foremost inflammatory, and it's that bacteria probably make it worse or take advantage of the situation is kind of what I tell my patients. Because if we could cure HS with antibiotics, if it was an infection, we would have done that by now because people have gotten every antibiotic known to man. And it just keeps kind of showing back up.
Yeah, I agree.
So I'm going to jump in.
Oh, yeah.
Sorry, Tiffany, with a little overview, and Tiffany's going to jump in a second with some of the details, but just stepping back with a kind of 10,000 foot view. Number one is this condition has treatments. We have guidelines, and I think one of the oldest things that I was taught ever in being a provider was my job was not to extinguish hope for people. It was okay to say I wasn't sure and I was going to look it up, but it was never to say there's nothing I can do for you. And I've had patients come and say they told me they didn't know what to do with me, like exactly what is on this slide. And there is stuff that we can do for them. So we want to give you some of those tools to put in your toolbox. And they're more than just palliative, meaning more than just a short course of antibiotics. And one of the things we definitely want to do is control these flares, because I've had people come to the office and say, I went to bed just fine on Friday, really excited about the plans I had this weekend. And you know what? I woke up with pus all over the sheets, because a flare can come up that quickly and that unexpectedly. And it really impairs people's ability to have a life, whether that's quality of life outside of work or ability to show up for work. And at least in the US healthcare system, work is usually where you get your insurance. And so you need the work to get the insurance to help you care for this chronic condition. And so what we're also trying to do is think not only about those individual flares, but what can we do to put them off? Because on the left-hand side of this slide, you can see the real damage that's accumulated to this person's underarm, where you've got some of this tunneling and scarring over top, the heaping up of this scarring. Even when we get rid of all of the inflammation, there's still going to be very visible damage here, and that will still be impactful to this patient, if not symptomatic and functionally impactful. On the right-hand side, we really want to kind of reinforce that over time you have episode after episode of acute flare, but it's not that people drop down to normal all the time in between. There's actually this accumulation of, in the background, this orange cutaneous damage, indented scars, elevated scars. And so to help people the most from not having the pain of the condition, but also not accumulate the damage or maybe even progression of this disease, we think of this opportunity to get people a diagnosis sooner and to get them on treatments that are effective as soon as possible. And so when we are thinking about treatment, we want to share these images with you because it helps you maybe triage how urgently somebody may need to get in to see us. Arguably, all of these people we can help, but someone in stage 1 has individual lesions. Very impactful, don't get me wrong. These things that look so little can be pain out of proportion, but we don't tend to see a lot of scarring right away. In stage 2, we're starting to see scarring. We're starting to see some tunneling, again, individual lesions that are actually connected under the skin. But in stage 3, we have tunneling that is coalescing. Many of these tunnels are connected to each other, and the inflammation of the HS is kind of overtaking this whole anatomic unit, which is the axilla. And so when you see people with stage 2 or stage 3, you can see the scarring. We can definitely help these folks. These are people that really need to get in more urgently, for sure. It's still urgent. These folks, there's stuff that we can give you, tools that we can give you that I think can help these folks still get in to see us and talk about next steps. So I guess, Tiffany, what I'm trying to say is everyone is suffering and we want to see them all. But if we had to get somebody in like tomorrow, it's maybe this person and then this person. But what do you think?
I agree with that. I also definitely agree with that. Even that patient with Hurley stage 1, that may look like it's a small degree of pain associated with those lesions, but patients can be in immense pain, even with the smallest nodule, because what we see on the surface sometimes is a lot larger underneath and has a lot more inflammation associated with it than what the surface will portray. And that's especially in those skin of color patients where you may not be able to see bright red erythema.
Yeah. So these are all folks that you can help too. I think it's just more about maybe speed of referral. And so this kind of transitions us into the North American Clinical Practice Guidelines. Just to refer to the bottom of the page here, if you go to our website, we have these on our website for free download. There's actually a website at the top here, which you might not be able to see, but it's hs-foundation.org. So we're going to walk through management, but I think just noticing that we tend to match the aggressiveness of our treatments or the side effects of our treatments against the aggressiveness or side effects of the HS that we're trying to manage. So that way we're not giving somebody much more aggressive, more side effect riddled therapy for stage 1 disease, and not vice versa, where the HS is having such an impact and having so many side effects, if you will, in somebody's life, but we're not giving them maybe as aggressive a treatment. We're going to walk through some of these medical therapies, keeping in mind you might be coming from primary care, where it's kind of within your wheelhouse to do a lot of this medical management. In derm, when they come to us, we're going to be really thinking about not only medical, but also procedural management and leveraging both of these as we take care of that patient. But we're really going to emphasize medical here.
Thank you, Jocelyn. So let's talk about what we want to do for an HS flare. So this patient quoted said, because of the location of the boil, I was really embarrassed to go to the ER, but I was in so much pain. So these are sensitive location areas. Patients are embarrassed to be there. So when they show up, the last thing they want to hear is that they shouldn't have come there, or that there's nothing that you can do for them and that now they need to wait and go somewhere else. So there's definitely things that can be done whenever and wherever a patient shows up with one of these flares. And we want to give you some tools for that. So what can be done right now is what we're going to focus on. Let's start with localized. So what can be done depends on whether or not the patient has a very focal area versus whether or not they have more generalized flaring in maybe both axilla and the groin as well, or if it's just 1 or 2 nodules in, let's just say one axilla or both axilla. So with localized disease, we often rely on intralesional triamcinolone or intralesional Kenalog, often doses ranging anywhere from 2 up to 20 or 40 milligrams per milliliter. Often what I do clinically, Jocelyn, is about 10 milligrams per milliliter or 5 milligrams per milliliter, making sure that I'm putting adequate volume in there. Is that what you typically are doing in practice?
Yeah, I usually go for the 10 milligrams per milliliter. And just based on the studies, like you said, it's not just like 1 or 2/10 of an ml, but it's almost always half an ml at the base of that nodule.
Exactly. So that can be really helpful. And we're going to talk in a minute about how studies have shown just how helpful intralesional Kenalog can be for those acute flares. So that can be offered in office, in an ED. We offer it very frequently in our dermatology visits to help with those acute flares. Another option is incision and drainage. Now, this is commonly done in EDs and urgent cares in primary care offices. The thing about incision and drainage is that we do it for abscesses that are inflamed to assist with pain. Oftentimes, you can use a scalpel, but we also use a punch device that really helps those lesions not heal over too quickly. We don't really support packing because packing really doesn't have the data to support it. And with INDs, almost 100% of the time, this abscess is going to reoccur. So our main goal with doing an IND in the first place is for pain relief. Packing can be very painful and the lesion is going to reoccur. So we don't recommend packing, but using that punch tool can really help keep the lesion open long enough to allow it to drain and to assist with the pain there. So we're not totally against INDs, but we do INDs understanding that this is not a boil. This is not usually an infection. This is an acute painful abscess that we want to drain for pain relief for this patient. So here, this is what I was meaning when I talked about the intralesional Kenalog can actually be quite helpful for patients. So this was a study where they injected Kenalog. I can't remember which one. I think it was Kenalog 10 milligrams per milliliter into the lesion. And you can see at baseline this red inflamed nodule that over the course of 7 days has almost resolved, or likely really has resolved. So intralesional Kenalog can help with pain within a day for these patients, but it can also help with other signs of inflammation related to those localized lesions. So there are a few steps for incision and drainage that we like to recommend. So the first thing is, please do numb these. Patients come all the time and tell us they've had INDs done, it wasn't numb. They have been under the impression from providers that you can't numb something with pus, it doesn't numb well. Yes, they can be numbed, and it truly can help patients with pain relief as you're doing these procedures. So we do recommend numbing all of the patients who are going to undergo an IND. Number two, I mentioned using a punch tool. And so this is an example. You can use a scalpel just for immediate acute release of any pus, but this punch tool can be a lot more helpful and doesn't require packing to keep the wound open long enough to allow for drainage. So number three, don't pack, please. And then number four, set the expectation. So INDs are meant for acute pain relief. They're not a treatment. They're not a surgery in the sense of the types of excisions that we or plastic surgeons may do. They are truly only meant to allow that lesion to drain. So what to do now when you have generalized flares? This can be a little bit more challenging. This means that the patient is flaring in multiple places. They often also report other symptoms of fatigue and just, feeling very, very unwell, psychologically, socially, impacted by these huge flares that they're having in multiple places. So we need to do a little bit more than inject a few lesions or do INDs. Here, often we will resort to short courses of corticosteroids. So in practice, I will often do a short course of Kenalog 40 taper over about a week or so. You could certainly do a dose pack for these patients. Often I've found in practice that they need a little bit longer than a dose pack, but that can be helpful. And then also adding systemic antibiotics. Systemic antibiotics such as tetracyclines can be very helpful for these patients. So often we dose 100 milligrams of doxycycline twice daily for longer courses than the typical 2 weeks that we may do for other acute infections. Typically, we're dosing these for about 12 weeks for patients to allow their pain and inflammation to get under better control. Now, doxycycline does come with adverse events of GI distress and potential photosensitivity. So some patients may have a difficult time tolerating it. The GI distress, we often recommend taking it with food, but not dairy, and that can be make it better tolerated for some patients. But then there are some patients who just cannot tolerate it. Minocycline is another option. Clindamycin is another option. Of course, with clindamycin, there are other risks such as C. diff, but it's not as frequent, and so we don't worry about it as much for the amount of time that we're going to give it to these patients. But it is something to counsel patients on. And so here are those systemic therapies and recommendations. So again, the doxycycline is going to be BID 100 milligrams and over a course of about 12 weeks so that it can serve more as a bridge to a next line of therapy, especially if they're having those generalized flares. They're likely going to need more than just short courses of antibiotics. That clindamycin is going to be 300 milligrams twice daily. And then again, you can consider minocycline if the patient can't tolerate doxycycline or has some GI upset with both Clinda and Doxy. So Jocelyn, what's your go-to?
Oh, my go-to antibiotic. Well, and I think this is one of the places, Tiffany, where we just lack evidence. Unfortunately, Tiffany gave you the best data we have, which supports the tetracycline class and clindamycin, and kind of goes back to what you mentioned earlier, Tiffany, which is the anaerobes. So we've got a lot of staph in these lesions and a lot of anaerobes. And so Clinda makes a ton of sense. But again, as providers, we don't love that C. diff risk, and our patients don't love it either. And so that's why it comes with that caveat of we usually try and get Doxy on board first, good staph drug, maybe not so great for anaerobes, but lower risk, I think, overall. I was thinking actually, so thanks for segueing, we're not really taking into account our patients who might be pregnant. So HS is happening to young childbearing potential women. Doxy is not going to be your drug for women who are pregnant, nor is it going to be your choice for children before the age of about 11 to 12, before they've gotten their permanent teeth in. And so in that case, or for people who haven't tolerated Doxy or have allergies, I tend to go with more cephalosporin class, amoxicillin, the combo of amoxicillin clavulinate. I'll occasionally go with trimethoprim, sulfamethoxazole, trying to avoid brand names, though they're so much easier to say. And so I think that's where the data really can't guide us. So it means we do have a lot of choices, but we can't tell you, what our third favorite antibiotic is based on data, because we just don't have it yet.
Right. I think Doxy, there's data, clindamycin and rifampin, that combination together, which is 300 milligrams twice daily for both of those. We have data there, but I think Doxy is a very frequent go-to for most of us. So with the prednisone, we do have to be careful. Prednisone is not meant for long-term maintenance, but it will help patients feel better quickly, and they will ask for it over and over again. And so I think a bit of education has to go along with the prescriptions for prednisone, but it can be helpful. Consider it when patients are having multiple lesions in multiple body sites. Here's the dosing, 0.5 to 0.7 milligrams per kilogram. And again, over 1 to 3 weeks. I find that dose pack just may not be enough to get the patient through that flare. You can do this with or without antibiotics. I usually add prednisone along with a more long-term antibiotic, like the 12-week of doxycycline and a very short course of prednisone to help with that immediate flare. And again, you want to avoid frequent or long-term use of prednisone. All right, let's talk about maintenance therapy. Okay, before we get to specifically talking about what we're going to do for more long-term maintenance therapy, I think it's important that the first step in treating is giving patients the information that they need, giving them accurate information, which may start with debunking myths. Patients may have seen multiple other providers before seeing you, as we mentioned, and they've heard a lot along the way. And so they may come to you with these perceptions of their disease that just isn't true, and you can help them tremendously by debunking some myths. So first, HS is not an infection and it's not contagious, and it can be so impactful when I actually say this to a patient. Next, weight loss is not going to cure HS. Some patients get better with weight loss, but weight loss has not cured HS for the majority of our patients. Smoking cessation will not stop HS. Patients may get a little bit better if they stop smoking. Their medications may work a little better, but it is not a cure for hidradenitis suppurativa. And hygiene is not going to stop HS. Better hygiene will not stop it. And so a lot of patients, whether or not they've been told this by providers, somewhere along the way, they picked up the notion that they have HS because they're not bathing enough, because, you know, it has to do with their cleanliness. And this is just not true. It can be such a relief for a patient to hear their provider say, this has nothing to do with your cleanliness. This is not an infection. It's not contagious. You're not going to infect your partner with this. All these things can be very helpful as we start to talk about management of HS.
Tiffany, I just want to throw in there that so many of our patients, because this happens in the genital area, so many of them have been told they have a sexually transmitted infection. And that sticks with people for a long time. And it's a barrier to them going back and getting care for the next flare, because they feel like they're going to get that news again and they don't want to hear it. And so I think it's just really important to pause for a second before you might consider saying that, because it really does impact, I think, people's identity.
I agree. Again, the same with the weight loss. Patients have told me that providers start the conversation talking about their weight, and they immediately put a wall up when that happens, because they've already heard that. They're usually already trying to work on their weight. And we know that their weight is not the cause or the cure for their HS. And so, yes, we do counsel patients on weight management, but starting off a conversation with weight, I don't recommend it.
Well, sorry to emphasize this. I think it's also just one thing is, it's really hard to go out and make healthy food choices and start an exercise routine when you can barely walk across the room from your pain. So just from a feasibility standpoint, we actually want to start that maintenance therapy first, right, get some wins. And then once somebody can walk comfortably, yeah, I think it's totally reasonable to have that conversation about maximizing your whole health. And maybe it also will help with your HS.
Yeah, I agree. So maintenance therapy, we're talking about bridging patients to follow up, and they're going to follow up with other specialists such as dermatologists, rheumatologists, plastic surgery, who have experience in hidradenitis, but bridging them to get to that point with the goal to improve disease control while they're awaiting their specialist care. So the goal here of maintenance therapy is going to be to improve their baseline symptoms and reduce flares over the next few months. So that means just a 2-week course of antibiotics is likely not going to be very helpful. We're wanting to think about how can we keep this patient flares under control for the next 3 months until they get in to see a specialist. And some of the things that we've talked about can be helpful. And then thinking about what we can do beyond that during that bridge until they get in to see us. So those long-term care providers may not be dermatologists. Sometimes they may be a primary care physician, depending on the area that a patient is in. If they have experience in hidradenitis, that would also be the person who would be taking over the care. But we want to definitely identify a long-term provider for these patients, whether it be dermatology, rheumatology, infectious disease, or plastic surgery, or a primary care provider. Jocelyn, so I'm in Alabama, and there are some areas where there's not a lot of dermatologists nearby. I do work very closely with primary care providers to help with management of HS. Do you find that to be the case where you are?
So I work in central Pennsylvania. I would say most of my partners are dermatologists out in other parts of central Pennsylvania, New York, and other places. And so one of the things that I think you and I benefit from, Tiffany, is just seeing a lot of it. And so we can get, really efficient at, what to do next, and partnering with, any of these folks, whether you're a dermatologist and, want backup, or you're a rheumatologist and can help us prescribe some of these meds that you're about to talk about. we can partner with anyone to help direct that care.
Yeah. So Jocelyn already mentioned medical management a little bit, but I just want to show this once more as it relates to the different stages and the treatments that we may choose for patients to bridge them over into seeing that specialist. So here you can see we're going to choose a medication depending on the stage, but I like that they don't necessarily in this table put a specific medication under a specific stage. It just depends on how the patient is doing, how the patient has responded in the past, and what you feel as a provider is going to best get that patient under control. So we talked a little bit about the tetracycline class. That would definitely be appropriate for stage 1, stage 2. Clindamycin, rifampin is another regimen that can be helpful. We start to talk about the adalimumab and infliximab. These are the biologic medications that we as dermatologists and other specialists may put patients on. And then there's other antibiotic regimens that can be helpful. We also bridge patients with hormonal therapies that are often prescribed by primary care providers that have been found to be helpful for hidradenitis, and we'll talk about some of those, as well as retinoids. So maintenance therapy can include topical regimens. Most of my patients, regardless of what stage they are in when I see them, I recommend a maintenance topical regimen just to keep flares under control. So this is even if they're not flaring, if they're in remission, I want them doing these things pretty frequently, usually every day, to try to prevent flares as much as possible. So these can be used for all stages. A lot of them are over-the-counter washes. Now, there's not a lot of evidence-based literature on these over-the-counter washes, but we use them in practice pretty frequently. So that would be the chlorhexidine washes, over-the-counter benzoyl peroxide, which these can be found in the acne aisle, and so they're usually pretty easy for patients to find them. And the zinc parentheone that we can see it sometimes in some different shampoos. Topical antibiotics, these are prescriptions, clindamycin 1% solution, cream, gel, or swab, depending on the patient preference, can be very helpful for these patients. And used with some of those antiseptic washes like benzoyl peroxide can help reduce antibiotic resistance to that clindamycin. Maintenance therapy would be those systemic therapies that we talked about. So here that doxycycline, 100 milligrams BID, planning on about a 12-week course of that. Patients may not be accustomed to 12 weeks of an antibiotic. So really driving home that we are aiming for anti-inflammatory management for a prolonged period of time beyond just 2 weeks that a patient may be accustomed to receiving an antibiotic for is going to be important here. Clindamycin and rifampin has been shown in the literature to be helpful, as I mentioned previously. This should be considered in patients who've said they've been on a tetracycline, they did not see response. Some patients may respond to this regimen of clindamycin and rifampin. Now, with rifampin, you do have to be mindful there's medication interactions. When we talk about this age range of patients and female patients having this condition more prevalently, you definitely want to think about oral contraceptives and that sort of thing that the medication may interact with. And you do have to warn the patient that it will turn their secretions orange. That can be very scary from a patient perspective. But clindamycin and rifampin is a frequent regimen that we will use for about a 3-month course in patients who failed tetracyclines. So here's what we may do on the other side of the bridge. So you saw these images earlier. And so often we'll have our primary care doctor stabilize. So let's take a look at this stage 1 disease. And Jocelyn, can you see my cursor here? You may not be able to see it. Okay, so we'll just talk about, so under that stage 1 disease, you can see the idea to stabilize may be to use something like a topical antibiotic like clindamycin, benzoyl peroxide, in addition to an oral antibiotic such as doxycycline. You can also add the intralesional triamcinolone injections for those very inflamed. I see about 3 lesions that I want to inject right now with intralesional triamcinolone. And then you always want to consider appropriate pain therapy and wound care, which we will get to soon. Now, on the other side of that bridge, we may be considering medications such as metformin, spironolactone, and others that have shown to be helpful for the anti-androgen component. We especially use these in our female patients with HS, regardless of whether or not they report flares with their menstrual cycle, but definitely if the patient is reporting flares with their menstrual cycle, we tend to add these and find them to be helpful to reduce flares. Now for this stage 2 patient, so we would recommend stabilizing them again with those oral antibiotics, pain therapy, wound care. And then this is a patient that it would be more appropriate when they see the specialist to bridge to a biologic and to consider procedures such as deroofing and other surgical procedures to help with some of those tunnels and scar formation. And then finally, this stage 3 patient, stabilization would include either oral or IV antibiotics, a surgery consultation, prednisone taper, pain therapy, and wound care for this patient. And then definitely this patient would need to bridge to a biologic or procedure. So as Jocelyn mentioned earlier on, this would not be an appropriate patient to put on 3 months of doxycycline with no plan to bridge. So I want to spend a little time talking about biologic. So currently the only FDA approved biologic is adalimumab. And here we're showing results from the Pioneer 1 and 2 trials that showed a statistically significant difference as it related to abscesses and nodules and an overall improvement in patients with HS. So patients come to us very fearful often of biologics. Either they have heard about biologics and they've had discussions with providers who are familiar with biologics in the context of patients with other comorbid diseases, and they're familiar with those risks that are related and that they see in those patients. So when patients are fearful, it's important to mention and to consider the risk and benefits. So also taking into consideration the risk of the disease. So the pain that patients are experiencing, the frequent flares, the frequent use of prednisone tapers, the frequent use of antibiotics that aren't usually stabilizing the patient if we're already, if we're considering a biologic medication in the first place. And then the psychosocial impact of having hidradenitis. So when we think about these things and we discuss medications in terms of the risk, the side effects, the impact that the patient is experiencing from the disease, having a conversation about a medication that will work on the immune system in the inflammatory pathways that we know are being activated in hidradenitis helps make a medication like this make a lot more sense to a patient. Jocelyn, what are some of the challenges that you have when you're wanting to prescribe a biologic to a patient?
Yeah, no, and I think to emphasize the point you made, which is, in the label for a medicine, it might mention something like lymphoma. And with adalimumab, much of the lymphoma happened in patients with inflammatory bowel disease, so not HS. Often younger male patients, not always HS patients who are predominantly female, and on concurrent immunosuppressants like azathioprine or mercaptopurine, which we're usually only using Humira as a solo immunomodulator, not with a concurrent immunosuppressant. So I think helping my patients understand your condition is different. Yes, this isn't, the label, but it seems like it's a higher risk with someone else. So I would say my patients usually come in concerned about, is this going to give me cancer? And I think also the worry, again, that they've concluded that their immune system is broken and kind of low. And again, in fact, you're telling us their immune systems are overactive, like they're working too hard. And so I think helping them understand, we're not trying to take their whole immune system and make it low from an already low state. We're taking kind of a specific part that's too good, too high, and just trying to normalize it a little bit.
Exactly. That's very similar to how I counsel patients. And, you'd be surprised the number of patients that have told me they've never heard this type of medication described to them in that way. They've only considered it in terms of what they've read and the side effects that usually apply to other patient populations. So I certainly feel like adalimumab, the biologics that we use in my clinical practice as well in the literature, have certainly shown to make differences in the disease as well as the quality of life of patients with hidradenitis. So pain management is a very important part of managing HS. The first the first goal in pain management, we should say, is to treat the HS. Addressing the pain without adequately addressing the HS is not really going to get us anywhere in terms of pain management. We use multiple different options for pain management: acetaminophen and NSAIDs. Just alternating that is often what helps patients through flares, through acute flares. Topical anesthetics, things that are found over the counter, for instance, Preparation H. I actually learned about this from patients. Preparation H, which has lidocaine, Boil Ease, which has benzocaine. These things are over the counter. They can be helpful for patients who are having acute flares. And considering other types of pain modulating medications such as gabapentin, pregabalin, duloxetine, venlafaxine. Actually, we as dermatologists don't have a lot of experience in prescribing these often for other conditions. And so we often will communicate with our primary care doctors to help us better understand how and at what dose and make sure that it's otherwise safe in our patients. But these are frequently used and can be helpful in our patients with HS. Tramadol is an alternative to conventional opioids that can be helpful in patients. And then considering collaborating with a pain management specialist. So we in dermatology collaborate very often because there's so many aspects of HS that we can't manage or we don't have the experience to appropriately manage. And so definitely we expect the same of all of our other providers that we're working with for HS patients. Pain management is its own entity in itself, and it can require specialist care for these patients with chronic pain. And so we often rely on our pain management specialists for help here. Any thoughts on this, Jocelyn?
I think the big one is really just helping patients understand that to help them get relief, we need to treat the HS. But I also need to keep in mind that our drugs don't work overnight. And so while we're waiting that, I usually tell people about 4 months to see how well it's going to work, you're coming up with some really great suggestions on how we can escalate in a way that hopefully keeps people safe, but also keep their pain control.
Yeah, this is actually one of the biggest complaints. When I ask patients, what could we do better? What are the gaps in management for them? They always mention pain management because not just are they in pain, they are also treated as if they're drug seeking. And so, that weighs to the burden, the heaviness of the burden of this disease. And so really thinking about managing pain as part of the treatment plan is important for these patients. So wound care, Jocelyn, I'm going to let you take it away.
Absolutely. And I think this dovetails off of the pain management because wound care is effective for so many of those symptoms that I mentioned. I said pain, itch, drainage, and odor. Well, it might not help with itch quite as much, but it's going to help with some pain just from putting a little bit of compression on these wounds to stop the air from hitting them. Very often gives people a little bit of pain relief. The drainage, it's going to collect it. So many of my patients have been using paper towels. They come in with paper towels, stuffed under an arm, under their breast, in their groin. And we will work often with them and with their insurance to try and get something that's usually an alginate, so high absorption. There's lots of exudate with HS. The challenge is that some insurances just don't cover it to the extent that it's affordable. And so we'll work with people to leverage things like feminine hygiene products, which are meant to absorb, not stick to wounds. And so we can get pretty creative with things that are over the counter and don't always cost a lot. And like Tiffany mentioned, other people with HS have probably had to find solutions. So directing your patient to one of the online patient groups, patient advocacy groups, you can find some of them on our website, is also a really great part of management because they'll get solutions there as well. So I mentioned alginates. Fibers I use also as well. Foams a little less often because you can't usually get those covered for everyday use. Tapes, I think, cause nearly as much damage on the skin as the HS does for some patients. So trying to find less traumatic tapes, which are often silicone-based, like a contact layer or a border dressing, has been really helpful, though they don't always stay in place quite as well. And so there are also some videos online of how to use tube dressings to hold a dressing in place, especially for a place that's a concavity like the underarm and also highly mobile. So lots of really great resources online, especially from our patient advocacy group partners. And I mentioned some of these other things. And so I think Tiffany mentioned a lot, which is, as dermatologists, we want to manage the medicines. We can do some of these procedures, but I'm really honest with my patients, which is, I am not the person you want trying to manage your depression or arthritis or high blood pressure. And so I ask them, my patients, I really need your help to make sure you're connected with your PCP. If you don't have one, I need your help having a PCP. And it's because of these things. HS and that inflammation in the skin is not only in the skin, it is systemic inflammation. And we've learned this lesson from psoriasis. So in HS, this is all supported by data. Our patients have an increased risk of depression and anxiety, as well as a higher rate of completed suicide and attempted suicide, suicidal ideation, tobacco use, other substance abuses. Spondyloarthritis. So arthritis, both centrally and peripherally, is increased in HS. And in some instances, we need help documenting that there is this arthritis, because if there is, we can get other drugs on label for that indication, which might help both the arthritis and the HS. Same for inflammatory bowel disease. We'll want to screen those patients to see if they have symptoms. Again, both with the aim of diagnosing early, but maybe leveraging medicines that are maybe labeled for inflammatory bowel disease, but help with both HS and inflammatory bowel disease. Many of our patients have signs of polycystic ovarian syndrome. Sometimes we're thinking about that diagnosis and making sure that they get in with a GYN or they come with it already. The nice thing about well, I shouldn't say that. I mean, the fortunate thing about having both of these conditions, HS and PCOS, is that we have medicines that, again, can be leveraged for both spironolactone, metformin, combination birth control, and other things. And then metabolic syndrome and cardiovascular disease. People with systemic inflammation, it's not only, again, in their joints and in their skin, it's in their vessels, contributing to these outcomes. And for all of these things you're seeing on the screen, the rates or odds are about 3 to 4 times higher for all of these compared to people without HS. And so that often will trigger us as the person who might be directing HS care to make sure that we're doing almost team-based care and bringing in collaborators when we need them. And the number one people on that list, I should have put first bullet, is primary care. So that's family and community medicine, internal medicine, and pediatricians. And I would say even pulling into that gynecologists and OBGYNs. I double counted you there, GYNs. But I think also soon after that are people who can help with the mental health impact of HS. So that's psychiatry, licensed social workers, and other counselors. And you can see all of the folks who I think really can play a big role in helping our patients with HS. So to wrap it up, number one, want to thank Tiffany for all of your incredible help. Learned so much working with you putting this together. So HS, chronic inflammatory disease that is marked by these acute flares, but it is chronic. It is long-term condition. And so when you have somebody who comes in with that second, third, fifth, 7th they still haven't gotten the diagnosis, you're going to be the hero of the day. You're going to give them a name for what's happening. And then hopefully we've given you some tools that you can pull out to help that patient right then, whether it's incising a lesion to help give them some acute pain relief, but letting them know, you know what, it's probably going to come back. It's already shown us that it's come back 3 or 4 more times before. So let me give you something that can help you get under a little more control while I'm referring you to this person who can help us manage this HS. And so those first line maintenance therapies are probably going to be antibiotics. Now, we told you this is a chronic inflammatory condition, but it's worsened by bacteria. So we're using antibiotics to remove the trigger. And I think that's how we can explain it to our patients. And we can explain that doxycycline has been shown to have some anti-inflammatory properties. So we're using it not only because it's an antibiotic, but because it's anti-inflammatory. We've also gave you a couple of other antibiotic regimens to consider, keeping in mind that some of these antibiotics aren't the best choice for people who might be pregnant or who are young in the pediatric group. And again, that the opportunity here is that there's a growing number of people who know about HS and can pick up that management after you've bridged them with that therapy. And that this is going to be long-term management, and it's probably going to involve some medicines, some procedures, and maybe some other folks. And so we hope that we've given you enough to be somebody's hero the next time they come in with HS. Thank you.
Thank you.